We're back for the second part of our symposium today. And our first speaker of this portion is Dr. Leonor Hernandez Aya. Dr. Hernandez Aya is going to talk about the very exciting field of cell therapy and how it has made its way into the treatment of melanoma. Dr. Hernandez.
Good morning, everyone. My name is Dr. Leo Hernandez. I'm a medical oncologist at the University of Miami. Thank you to the AIM at Melanoma Foundation and to the organizers for inviting me to speak with you today. So I will be talking about cell therapy, which is a very exciting new treatment options for patients with melanoma. And my goal is to explain to you and your families what this therapy is, how it works, and where we are today. So this is the outline of the talk. So we'll talk about what cell therapy is, how tumor-infiltrating lymphocytes or TIL therapy works, who might be a candidate for TIL therapy, what the benefits, risks, and what to expect when someone is going through this therapy, and also recent advances and clinical trials in this field. So let's talk a little bit about what cell therapy is, and I will start by a brief history of how we got to this point. So the idea of using the immune system to fight cancer is actually not new. Over 100 years ago, a physician named William Coley, which he's often called the father of immunotherapy, he used mixtures of bacteria known as the Coley's toxin to try to stimulate the immune system to attack cancer. And he treated many patients, mainly with sarcomas, injecting this mix of bacteria. And there were very encouraging and positive results. And this basically planted the seed for what we would later become the field of cancer immunotherapy. Then in the 1970s and 1980s, researchers learned how to grow immune cells in the lab. And I think that's when the field really started to make more progress, because now we could actually test how the immune cells can recognize cancer cells and what the mechanisms are to get rid of them. And one of the true pioneers is Dr. Steven Rosenberg at the NCI. He developed the concept of adoptive cell therapy, which is basically taking the patient's own immune cells, expanding them in large numbers, and giving them back to fight cancer. And his early work with tumor-infiltrating lymphocytes, you can see that this was a publication from the 1980s, mentioned TILs, tumor-infiltrating lymphocytes, that showed very promising responses in melanoma patients. And this kind of laid the groundwork for the therapies that we have today. And then later in the 2000s and early 2020s, then the new treatments that we are using with immune checkpoint inhibitors. And now we have a renewed interest in TIL therapy, because now we can do it in more centers, not just at the NCI, like where Dr. Rosenberg was doing his work. So, and these are some examples of patients that Dr. Rosenberg treated back in the 1990s with melanoma. These are just pictures that are, this is the liver of a patient with melanoma with multiple metastases that, unfortunately, at that point, there was really no effective therapy options. And after getting TIL therapy, what we call the first generation TIL, there were significant and durable responses, eliminating basically the tumors from the liver. and in this case, from the lung. So there was, again, this very remarkable interest in this form of immunotherapy. So when we talk about adoptive immunotherapy or cell therapy, these are the key principles. So what we're trying to do is we're using the immune cells, your immune cells, or each patient's immune cells, that they are already attacking the cancer. They're specific, and we know that they can kill tumor cells. So we take them, and we know that they are reactive. So they're basically taken and then activated. We cultivate them to increase the numbers, and then they are transferred back to the patient. So one of the problems why we think that a lot of, several of our treatments don't work very well, like checkpoint inhibitors or other form of immunotherapies, is because we may not have, or that particular patient may not have enough quantity of the immune cells to do the job. So this form of therapy brings the solution to basically grow the cells in vitro in the lab, and then activate them and then transfer them back to the patient. So it's giving the solution to that problem of that we have seen. This basically means that we can collect or engineer immune cells and give them back to the patient. So that's the goal. And when we do this, we can boost the number and activity of these cancer-fighting cells. And I included here a figure of what all the cells that could be infiltrating what we call the tumor microenvironment. So there are multiple cells that are actually living and infiltrating the tumor that when we take them out, we can expand the ones that are effective to kill cancer cells and then give them back to the patient. So there are two main families, or I like to think about two main types of therapy. One is called autologous T-cell therapy, which is using your own cells, which is what we're doing in melanoma TIL therapy. And then allogeneic type of cell therapy, which is using donor cells, so cells from a different patient. This is in research in melanoma. So we're gonna focus the talk today about autologous cell therapy, which is using your own cells to try to fight the cancer. And the common types that you may hear about TIL therapy, engineered T-cell receptor therapies, and CAR T cells. And we're going to talk a little bit about those and the ones that we use in melanoma. So now let's dive in to talk more in detail about TIL therapy, or tumor-infiltrating lymphocytes. And these are immune cells that are already in the, so yes, these are immune cells that, as I said, are already inside your tumor and trying to fight the cancer. So in the lab, we try to expand them to then give them back to you in billions in order to help fight the cancer. So this is the therapy step by step, and there are several key steps in this process, and that's why this is it's a team effort, with the patients, with our surgeons, our cell therapy specialists, and so this requires infrastructure to be able to do all this. But basically, we start with the patient here with removing part of the tumor. So a surgeon or an interventional radiologist will remove a small piece of tumor. It's about 1.5 centimeters, or a little more if we can. But this piece of tumor will provide us with the T cells that already recognize the cancer. And then those T cells are grown in a specialized clean lab, and then they are expanded over several weeks. So this process can take, about 4 or 5 weeks. And then there will be a lot of quality checks to make sure that the product is safe, and then to give back to the patient. And then once we know that the product is ready, then we need to prepare the patient for the infusion. And to do that, we admit the patients to the hospital. And then before we give back the infusion of the cells, we have to do a short course of what we call low-dose chemotherapy. It's basically 7 days of chemotherapy. That what it does is preparing the body, opening space in the system to then be able to receive billions of this very active fighting T cells. So this chemotherapy reduces the competing immune cells in your body, and then helps the new TILs to grow and engraft in the system. And then once we complete the chemotherapy part, is the infusion day, and that's when the TILs are given back to the patient. And sometimes it's one or more bags, but during that process, the patient is admitted, is being closely monitored by the care team. And then after that is what we, the after infusion portion of the treatment is when we give supportive medicines, and we give immune stimulating treatments like interleukin-2 that are basically given to help the T cells work better. So during that time, the patients are monitored in the hospital, and then we once they're ready to go home, then they're discharged, and after that we monitor them in clinic. So in summary, this is a one-time therapy. We do this once, and this involves removing the tumor cells, growing those immune soldiers in the lab, and then giving them back to you in much greater numbers so they can fight the cancer. So that's the general process and about TIL therapy. And I want to talk specifically about the treatment that was recently approved for patients with melanoma. So you may see this name out there. So it's the Iovance is the company that is manufacturing the TIL therapy. And the product is called lifileucel. It's also known by the brand name of Amtagvi. But this is their first-in-class autologous TIL therapy. And now we have the process that I explained to you before. So the difference that Iovance made was they were able to basically streamline the process and learn from all that success from the NCI processes, but then they developed this centralized process that is now scalable and can be used on multiple centers. So we have to they will manufacture the cells, for us, and then ship them back to the patient. So the results from the clinical trials that basically led to the approval of Amtagvi or lifileucel are shown here. So this trial enrolled patients with advanced melanoma who had already received multiple lines of therapy, including checkpoint inhibitors and targeted therapy. So these were patients that had no really good options of therapy, maybe palliative chemotherapy as an option, and they give them this treatment with the TIL therapy. And here you can see what we call a waterfall plot, where each of these bars is a patient tumor. So when the bar goes down, it's because the tumor is decreasing in size from the baseline. So you can see that the patients that were enrolled in this trial, a large proportion of those patients actually had a reduction in the tumor burden. And, specifically, we saw objective responses in 31.4% of patients, but then a large proportion of them had some form of tumor burden reduction, which is, again, remarkable for patients that don't have really, any other options. And even some patients, down here had complete responses, which means that the tumors completely went away with this therapy. So among those patients that had a response, the median duration of response was over 3 years, and some responses are still ongoing. So in terms of side effects, I think it's important to realize that the reason why we give this treatment in the hospital and the reason why we have to admit the patients to the hospital is because most of the side effects, there could be high grade or severe side effects associated with TIL therapy. And those side effects typically happen in the first 2 to 4 weeks after this treatment. So those first, and as you can see here is, small bars here representing the patient, the number of patients that have, or the number of adverse events that we're seeing. And as you can see, most side effects happen within the first 2 weeks while the patients are admitted, but we have them closely monitored. And those side effects are mostly related to the chemotherapy that the patients have to receive, and also related to the supportive IL-2 therapy that they have to get to help those cells. And then once they are discharged, maybe after 3 or 4 weeks, normally 2-3 weeks, they may stay in the hospital. And then the side effects after that, this is month 1, month 2, month 3, then we don't see really more side effects. So this time here is critical, and that's why we admit the patients to the hospital. And then we're seeing the median overall survival was 17.4 months, but about 20% of patients were still alive at 5 years after they received this therapy. So this is just a summary of the trial. It enrolled about 153 patients, and this is the numbers of what I showed you here. So the main side effects, like I was explaining, are related. Those side effects related to the chemotherapy, the low blood counts, like low platelets or anemia. But we can see infections from febrile neutropenia, and we can see side effects from the IL-2. Like capillary leak syndrome that we have to be very careful about, because again, there could be severe and even lethal side effects. So we monitor those patients very closely, and this is an example of a patient that received lifileucel in the clinical trial, and this patient had this tumor on the side of the right of the axilla, and then had a good response. This is a tumor in the lung, also responding to the treatment, pre-TIL, and then 3 months after therapy. And as I said, some responses can be durable. So the key takeaways from this therapy, it's in summary, this is a ready to infuse autologous TIL therapy. So it's made from your own tumor-infiltrating lymphocytes, and it's a one-time therapy. It was developed by this company called Iovance. So we have to, we collaborate with them in order to manufacture this treatments for our patients. And then in February of last year, the FDA granted accelerated approval for this therapy. And now there's also a clinical trial evaluating lifileucel in the frontline setting. So basically, in patients that are newly diagnosed with metastatic melanoma. So I included this slide to talk a little bit about the timeline and logistics. So like I was saying, typically this is a one-time therapy, but it involves a lot of planning, a lot of coordination with multiple teams. So we expect to, after the tumor is collected, it can take 1 to 5 weeks to grow the TILs, and then the treatment in the hospital that can take 2 or 3 weeks, followed by recovery and the frequent follow-up. So it's very important that if you're considering this trial, or your doctors are discussing this option, for you, that we have to talk about arranging support and sometimes local housing if you're traveling. Discuss work, school, and family schedules for that time. So who might be a candidate for TIL? So again, like I said, that trial that led to the approval of this therapy involved patients or enrolled patients that had metastatic disease. So this is for patients that have already a melanoma that has spread to other sites of the body or returned after standard therapies. So the patients have to have adequate organ function because, as we said, it involves hospitalization, chemotherapy, and treatments that can have effects on the cardiovascular and pulmonary system. So we have to, do some evaluation to make sure that a specific patient is a candidate. Also, we need to make sure that the tumor site can be safely removed for the manufacturing process. And, who may not be eligible? I will say patients that have severe or uncontrolled medical conditions, or, inability to tolerate chemotherapy and supportive medications like IL-2. Or patients that don't have a tumor site that can be safely sampled. So your oncology team will have to discuss all these details and other alternatives that, like we discussed, there are new trials that are trying to investigate other forms to be more tolerable for our patients. I just gonna skip this part. So one of the most common questions is, where can I get this treatment, or where can a patient receive this treatment? And lifileucel is only offered at certain authorized treatment centers across the country. So these centers, again, have the staff, the labs, all the infrastructure that is needed to safely administer this TIL therapy. So there is this online resource on the website of AMTACV, where patients and caregivers can search for the nearest authorized treatment center. And there are, this changes every, week, month. So it's important to be updating. And then I like to highlight that at the University of Miami is currently the only authorized center in South Florida. So this means that patients here in the Miami area don't need to travel out of state to access this therapy. We can provide it right here at Sylvester. So let's talk a little bit about engineered T-cell receptor therapies, because this is another exciting type of cell therapy. It's still undergoing, it's in research in clinical trials, but the basic idea of autologous or engineered autologous cell therapy is that instead of using the lymphocytes that are infiltrating the tumor, what we do with this is we use the T cells. We get them from the blood, so we don't extract them from the tumor. We just get them from the blood, the T cells that are circulating, and then we genetically engineer them with a special receptor that is called a T cell receptor. And this T cell receptor is designed to recognize a very specific protein in the cancer cell. So, and this is important because sometimes, cancer can hide from the immune system. And by giving a T cell that it has an engineered receptor that is very potent to find the specific target in the cell, is like giving those immune cells like a new pair of glasses to see the cancer better. So this makes the T cells more powerful, precise, and they can recognize the cancer cells that they may have missed before. So this is still, as I said, in clinical trials for melanoma and other solid tumors, but there's a lot of progress. And basically, is the process. What is different is that we don't have to do surgery to remove part of the tumor. So what we do is we collect the T cells from the bloodstream. We do a process called leukapheresis, so the white blood cells can be collected, and then they're sent to the lab, and they can be activated, and then they can go through this process of genetic engineering for this very specific T cell receptor, and then those cells are go through a process of proliferation, and then we can give them back to the patient for treatment. So thinking about this, obviously we have to think about what is a good target, because we are making these genetic modifications to the lymphocyte to try to make it stronger. So a good immune target for a T cell receptor is basically a target that has to be specific to tumors, but not in normal cells. So we can maybe decrease the risk of target toxicity. It has to be expressed in high enough quantity to effectively eradicate the tumor, and it has to be expressed in a variety of cancers to be more applicable. So PRAME, for example, is a very promising target in cancer immunotherapy. So, for example, in melanoma, it's expressed in over 95% of patients, and that's why this protein has been subject of clinical trials trying to develop very specific receptors to PRAME. And one example is this platform by a company called Inmatix that we have here at the University of Miami that is a T cell receptor targeting PRAME. So we have been participating in these clinical trials, and this is basically what I just explained. But what was very promising is the responses that we have seen with this therapy. So as you can see here, most of the patients, or a large proportion of patients that received this cell therapy, had reduction in the tumors, and so close to 55% of patients with melanoma that had progressed on multiple therapies received this treatment and had a very good response. So because of this, we are participating in a large trial to try to get this treatment to be hopefully approved, and we'll see if it's better than what we currently have available. So just to wrap up, I want to briefly look ahead and talk about what is on the horizon. But this field is moving fast, so we're trying to use combination therapies. So combine, for example, checkpoint inhibitors with TILs, and then also generate the next generation of TILs with gene editing or new targets for engineered T cells. look for biomarkers to try to see which patients can benefit the most, and then maybe make them more tolerable. And there are different trials that are basically looking into that. And this is one trial that it's available and that is very exciting. I don't have time to talk about details for this, but this is, again, participating in clinical trials is important. So I think here I just this is my last slide with some tips for patients and caregivers. So talk about your patient, talk about with your doctors about this treatment, and see if you might be a candidate. But there are some things that you can are in your hands to be a candidate for this. So I just included that there. And I think I'm gonna end up here because I'm running out of time, but I can answer any questions that you may have.